Okay, good afternoon or evening, everyone. Welcome to this online seminar organized by Syty, the Finnish Association for Psychedelic Research. My name is Samuli Kangaslampi. I'm the current chairperson of the association and will be hosting tonight's talk. Just a couple of technical notes first. Tonight's session will consist of a presentation or talk by our esteemed guest and a questions and answers session. So you can post your questions for the speaker at any time in the Q&A session on Zoom. So you should find the button for that on your screen, probably at the bottom of your screen. And you can also vote for questions others have posted if you want to hear them answered. So during the Q&A session, if I select your question to be asked, your status here on Zoom will be changed to panelist. This means that Zoom may reconnect you to the event, so this might take a couple of seconds. But after that, you can then open your microphone and ask your question. If you don't want to ask the question yourself by using your microphone, you can also indicate this at the end of your question. When you write it, and I will then read your question to the speaker. Tämä webinaari on englanninkielinen, mutta kysymyksiä voi esittää kirjallisesti myös suomeksi ja käännetään niitä tarpeen mukaan. Eli kysymyksiä voi jättää sinne Zoomin Q&A-osioon. Ni kan också ställa frågor på svenska med hjälp av Q&A-funktion i Zoom och vi översätter dem då. Please do note that this event will be recorded for later publication on our YouTube channel at youtube.com/syty. Now then, tonight we're very happy to have with us Marcela Otalora, who is going to talk to us about MDMA-assisted psychotherapy, more precisely about what exactly happens in an MDMA therapy session, the challenges of healing from post-traumatic stress disorder and how MDMA may help in that, as well as the inner-directed approach utilized in current trials of MDMA-assisted therapy. Marcela Otalora started her career as an installation artist and teacher. She has a Master of Fine Arts as well as a Master of Arts degree in transpersonal psychology. And for more than 20 years, she's been in private practice, working primarily with PTSD. In addition to working with trauma and PTSD, she has dedicated her professional life to training and research and has worked on several studies sponsored by MAPS as principal investigator and therapist using MDMA-assisted psychotherapy for the treatment of PTSD. She's also acted as lead trainer and supervisor. As a researcher in the field of psychological trauma and PTSD myself, I'm acutely aware of the sort of devastating impact trauma-related disorders can have for people's lives and the urgent need for new forms of treatment. So I'm very much looking forward to hearing about your experiences and points of view on this topic, Marcela. I'm very happy to have you with us here tonight. So please go ahead, Marcela, the stage is all yours.
Thank you. I'll share my screen. Can everybody see that? Is that okay?
Yes, looks fine to us.
Okay. Hello, everybody. Thank you so much for inviting me. And I look forward to your questions and to sharing with you a little bit about this work. So I think more important for me is how to really create an environment where we can treat people with trauma. Here we go. Okay. So starting with the challenges of working with trauma. So trauma is a very serious health epidemic and is very pervasive in nature. So it really affects in many individuals and millions of individuals, and it is a constant. It is like the effects of it, the effects of having PTSD due to trauma affect us every single day. And in the treatments that we have right now, the existing treatments are about 25 to 30% effective, and they have a big dropout rate. And a lot of times what we hear from people with trauma that come into the study is about being re-traumatized in a modality that they've used before, or in different settings like agencies and hospitals and places where they go to get services, where people are not trauma informed, and so they create more harm. So in the United States right now, about 8 million people suffer from PTSD, and it's 350 million plus in the world. So you can really understand how we really need more effective treatments to treat PTSD. So it's one of the reasons why we chose specifically PTSD, not that MDMA therapy would not work for other modalities, but because this is so pervasive and is so prevalent that, that we really want to help as much as we can to bring a new modality to work with PTSD. So some of the implications of unresolved trauma on an individual are that we've seen, especially in our study, is a sense of disconnection. And it's a disconnection from the self, a disconnection from the world, a disconnection from other people. And so it creates this sense of isolation, in a sense that we no longer have access to the essential parts of ourselves, because there needs to be a lot of coping strategies just to survive, to be in the world. And, you know, a part that I really see that is so, that is very sad, is that there's a lack of being in the present moment. So learning from the present moment is difficult. Curiosity, there's very little curiosity because we're so consumed by trying to manage our system, so that our nervous system, so that we can function. So this sense of ruptures that continuously happen all the time, and this sense of not being able to participate in society, participate in the world as it is today, because it's constantly being taken back to a place that was unsafe, where there wasn't a sense of well-being and there wasn't trust. And if you think that a lot of trauma is caused by another individual, and that we need trust and we need connection in order to heal. So, so this makes it incredibly, incredibly difficult to treat, and oftentimes misunderstood, that people with PTSD specifically get misunderstood because they have to create a world that can be safe for them, that is not always conducive to the way that the other people in the world live. So one of the ways to start this program was really talking and thinking about trauma-informed care. And it's something that we want people that work with trauma to have, and we hope that they have. So it's this paradigm shift of, instead of like, what's wrong with this person, it's more like, what is it that what happened to this person that they have these way of behaving, for instance, that they need to do, that they have hypervigilance, that they're fearful, that they feel that they can't actually trust, right? And then to begin to establish a sense of safety in the world, in their world, with a team that actually feels safe to them, understanding their symptoms, not from a pathological standpoint, but really understanding how is it that their symptoms are affecting their life. Cultural responsiveness. We have people from different cultures, and we want to be culturally responsive about where they come from, what are their belief systems, where did they get support from, where do they feel the safest, and to begin to create that sense of connection. If you think about a trauma modality, working with trauma, connection, relationship, it's really what is essential. And then, you know, I put here the last one in terms of keeping in mind that what remains alive from the traumatic experiences resides in the body. So really having an awareness of how it affects their body, how they get triggered, how their nervous system gets affected by different triggers in society that come in through their senses. So starting from this place of really understanding the trauma-informed care, the MAPS model that we use to treat PTSD starts with those principles of trauma-informed care, which I'm going to talk a little bit about: safety, trustworthiness, collaboration, choice, empowerment. And then we add to that MDMA, its non-ordinary state. And I'll talk a little bit about how MDMA, what the effects of MDMA do to help actually a person that is working with this, with their trauma. And then introducing the inner healing intelligence, the part of themselves that actually takes them back to their essential selves and is the part that knows how to heal and knows what they need in order to heal. So our modality is very much based on humanistic, transpersonal, interdirective approaches, and adding to it integration at the end, making sure that what has happened in the treatment can be integrated into their life. So starting with safety. So the safety is medical safety, physical safety, emotional safety. So in our modality, we want to really establish this first. What is it that allows them to feel safe? Set and setting is an important piece of this, right? How do we create an atmosphere where a person can feel safe, where their questions are answered, where we as therapists know that we can hold space for them no matter what they're feeling, no matter how intense their emotions are, that the therapists are trained and prepared to hold that safety place for them so that they feel that they can do it, that any expression that they have is okay. Trust and trustworthiness. So, and these are participants in our studies. And so earning a participant's trust, not starting from this place of feeling that it's not automatic that they're going to trust us, that we need to earn their trust through self-awareness, through having done our own work so that we understand what's ours and not bring agendas into the space, to manage their emotions, their sensations, their reactivity, to really understand our biases so that we can be fully present with them in the room, and that we understand what comes from us and what they're presenting. Another place of trustworthiness is presence. To really be able to be with them, to not make assumptions, to not interpret what they're saying, but to ask questions and to begin to gain that trust, to answer their questions about us, who we are, and to prepare them as much as we can for the experience that they're going to have with MDMA. Because with MDMA therapy, there's a lot of unknowns. We don't actually know for what's coming into the room, especially if we're going to be in the present moment experience. So to give them as much background as possible of things that we do know, things that they can expect, things that they can expect about the medicine, things that they can expect about the room itself, like how we as therapists work with them. We always use a 2-person model. So letting them know that they're never going to be left alone. One of us will always be there, finding out that safety for them, right? What happens when one person stays in the room and the other person leaves? Are they going to feel okay with that? And what is it that they need in order to be okay with that? Collaboration is an important piece. because we don't want it to be, this is not a hierarchical model. So it's not that we know best as clinicians. We want it to be a collaborative project, that we're being with them, we're not doing something to them. We are engaged with them with open channels of communication, that they're part of designing what their healing looks like, validating their progress and their strengths, and getting input from them, and permission to do any intervention that we do. So we invite them to do things as opposed to telling them to do things. We want it to be as collaborative as possible. We want them to have choice at any step of the way, that they have a choice to leave the study, that they have a choice to not take the medicine if they arrive on that day and they decide that they don't want to take the medicine, to maintain their integrity around every step of the way, around the choices that they have, and to let them know when they don't have a choice. Like, for instance, there are very few instances, but one of them is if they've taken the medicine, we ask them to stay in the room with us for 8 hours. So that's one part that we're saying, this is not a choice once you take the medicine. But to really be curious about what their choices in life. One of the things that happens with PTSD is that choice is taken away, that oftentimes choice was not available, and the boundaries that they had were not respected. So part of creating this set of boundaries is respecting their boundaries, respecting the boundaries of the study, and giving them as much choice as possible. And then empowerment, that whatever we do, whatever intervention we make is in service of their healing and in service of fostering their recovery. So that they are the ones who are doing this, right? That we are not creating the healing. They are creating their own healing. And how do they feel empowered so that they can move forward with that, with whatever insights they gained, that they're empowered to move, that it's not, that it's not up to us, and that we can be there to support their process, but that we're actually not not doing the healing. So, so why MDMA? Why MDMA? So MDMA creates a lot of empathy, and it's relational. So here are things that for somebody with PTSD, it's often really difficult to do, difficult to establish that trust and that connection with therapists. And with MDMA, MDMA facilitates more of that trust. So if you think of it as MDMA deactivates the amygdala, so there's less fear response. So the fear is more manageable, but it's still there. So it doesn't take it away, but it's manageable. And it activates the frontal lobe. So there's a lot of insights that can take place. It also releases oxytocin. So this sense of bonding, this sense of being one with another, a sense of trust in the environment that is happening at the moment. So this is like the opposite of what happens with trauma. What happens with trauma is that the amygdala gets activated, much more activated. The frontal lobe gets deactivated. There's not that much of a sense of being able to have insight and being able to think. So it's resource rich. It allows, I often describe to participants that it's like when you're falling into the abyss, you think you're falling into the abyss because you're going into parts of the trauma that have been really difficult and challenging to be with. And that MDMA creates a net, like a safety net that allows to hold them, right? And so then they're able to dive in. They're able to go forward and to feel a sense of empowerment, a sense of connection to themselves. Their critic, their inner critic, their judge is not as loud and not as present. And they go into a non-ordinary state. And the non-ordinary state is beyond the familiar, and it broadens the consciousness, their consciousness. So it's an understanding beyond the individual as being separate. So they're no longer separate. They're able to discover and have an experiential knowledge that comes from them. And they're getting, they're believing that aspects of themselves that were marginalized now have a space to come in and have, it's a way of feeling generous and expansive with oneself. It's an intimate connection with oneself. And the part that we talk about a lot is the inner healing intelligence. I like this poem by Rumi. Your calling my name is my reply. Your longing for me is my message to you. All your attempts to reach me are in reality my attempts to reach you. So the inner healing intelligence is the belief that every human being has the capacity to heal itself, and is characterized by the quality of self-love and self-trust. And with MDMA, this voice, this part of oneself that sometimes this very tiny voice with PTSD gets magnified, and we're able to really listen to that part of ourselves that knows what we need in order to heal. So it's a fostering, it fosters a deeper connection with oneself. And then the inner directed approach, that we are not the experts, that we're not going to direct where they go, that we're going to follow. So it's not a technique, it's a philosophical stance. It's an attitude that we as clinicians believe that the participant does have the capacity to heal themselves, and that whatever comes up in the session comes up for healing, whether we understand it or not, whether we know what it's there for or not, that we trust it and that we follow it. So we're not introducing things. We're really focused on the present moment and what the participant is bringing to that present moment, and that the participant is the agent of change. So this is what the inner directed approach is. We're not bringing things in. We're not having agendas about what they need to be doing with what. We're there to support their process. And that it is like an alchemical process, meaning that we don't try to get rid of anything. So that many times people with PTSD feel that they need to get rid of a part of themselves that was wounded. They need to get rid of a part of themselves that has shame. And this modality is about including every part of the self and how they transmute that, but remain connected to every part of themselves instead of trying to get rid of something. Integration is also very important, because if you think about sometimes, not every time, I think sometimes when people do psychedelics on their own, they can have very powerful experiences. But part of it too is that the integration of that experience is just as important. How are they going to carry it into their future? How do they begin to not need to change their past? This one is really important because people with PTSD also feel that part of their healing is about changing their past. And with the modality then comes in this piece, I don't need to change my past. What I need to do is include it. And how do I include it in my present moment? How do I include it into my future? How do I have it be like a living document rather than something that has that, you know, has an outcome and needs to look this way, but just being open to responding to their future based on the insights that they've had. So it's not really goal oriented. It's not attached to a goal. It's attached to being in the present moment with themselves and the insights that they have had. So one of the ways that I explain maybe a little bit about the trends of trauma, that the trauma sits in the middle and it's pretty big and it's surrounded by all these different parts that defend from the world, right? Fear and distraction and shame and isolation, the body as the enemy. So all these are protecting the trauma itself. They actually protect the trauma, because then it's, how do I keep the trauma at bay? How do I keep it from manifesting itself? And then with MDMA, all these other pieces begin to come in, and the trauma is not such a central piece, but it's still there. But it takes a side, it goes to the side, and all of these resources begin to come in, and there are resources that were already there. When one faces the trauma, goes through the sensations and the feelings and the memories, then begin to connect to these other parts that are a resource and that maybe have not been available. And so then both are there. The trauma is still there. These other pieces are there, but all of a sudden there's these other parts that are more, there's tolerance and empathy and self-reflection and curiosity, love for oneself and trust. And so then it's the movement towards wholeness. So that's what I mean by not getting rid of something, right? That they're still there. Those parts are still there. They can get triggered, but now there's also this wealth of resource, of internal resource that can come in to help. We do a little bit of a diagram. It's sort of it's a little weird to think about doing a diagram of a session, but I think it helps explain a little bit of how it begins the beginning phase, where a person just begins to feel the medicine. So we offer headphones and eye shades. The two of us are there with them, and if they want them, but we ask for them to go inside and really wait for them to start feeling the effects of the medicine. We ultimately, we want periods of them connecting with us and telling us what is happening, but also going inside and getting insights from themselves and finding out, sitting with the memories, sitting with the trauma. And so it begins to be very active, and there are waves. And so we explain that maybe there's an intensity and there's a lot of maybe fear, pain, suffering, and then that intensity will come down, and it's like a wave, and in the part that is down, there's a space to rest. There's a space where other things come in, like joy, feeling a sense of well-being, feeling a sense of connection, feeling a sense of being okay with themselves. So many times we have participants say, I didn't know that I had this part of myself that was so not touched by the trauma, that was intact. And so then they continue to do those waves. After an hour and a half, we offer a supplemental dose, which is always half of what they got first. So if they got 120 milligrams, they get 60 milligrams an hour and a half later. And this doesn't make it more active. It just expands this window up here where the activation of the medicine is the strongest. We do I'll talk about that in a minute. But and then the waves begin to get a little further apart, but they're still there. And this is about 8 hours later. 8 hours later, they're back down. They're integrated. They begin those last 2 hours where they don't feel the medicine so much is a crucial time for integration, for the beginning of like, now I don't feel the medicine, but I have all these insights. I'm still really open. My heart is open. I can begin to experience what I just learned about myself. So it's a really important time, those 2 hours that we are with them. So this is a total, from onset to the tapering, the effects, this is 8 hours. We also play music. Music is an important piece of the work. Music is not intended to create any kind of sensation, but more to support whatever they're feeling. So we have playlists that have that we do, different people do it different ways. For us, we have 4 different kinds of playlists. At the beginning, it's just very soothing and allowing them to just really be introspective. And then it's more active. The music can get more active and really match their state. And if during that activation, there's a sense of relaxation, we go back to that relaxing music, heart opening music. And then at the end, also integration music that goes back to being softer and more connected. We try not to use words that are in a language that they can understand. Sometimes there's a couple of songs that might have words, but we try to use not words so that they don't get influenced by that. But we play the music throughout. They can ask us to turn it off if they want, if we want to, but the music is very important and very supportive of their session. So this is the course of treatment that we do. We do a lot of screening, that is medical screening, psychological screening, and then the enrollment process. We do 3 preparatory sessions that are 90 minutes long. And then we do MDMA, the MDMA session that is 8 hours long. We do 3 integrative sessions, the first one starting the day after their experiential session, so that we're right there with them the day after. We have 2 different ways that some of our participants spend the night at the clinic with a night attendant that is in the next room. And so in some studies, they can go home with a support person that we have met before, and they bring him back the next morning for their first integrative sessions. Then we have 2 other integrative sessions, 90 minutes apart, about a week apart. And then the second session, and that repeats 3 times. And then we have a follow-up of a 1-year follow-up. We have, we're now doing some of the follow-ups for that 1-year follow-up from our first phase 3 study. This is a little bit of history of PTSD. As you can see, 34% of participants have had PTSD for 20 years or longer. Most of our participants have complex PTSD, meaning that it was more than one event, and childhood trauma, war, something that went on for longer periods of time. So they've had trauma for long periods of time, our participants have. So it's pretty severe. And in our, in our session, one of the things that we emphasize is that I've talked about before, is this idea of integration. How important it is for them to begin to integrate their experience into their world. And sometimes this is challenging because we've had participants that will say, I don't know what to do without my PTSD. I don't know who I am. And so there's a period of destabilization of before they can find new ways of coping that are healthier. than the ones they used before, there's this period of uncertainty of like, I don't want to use the ones that I used before, but I can't quite first integrate the ones that I want. And so really being with them during that time, and this is what we do during integration. We also do 14 days, every other day, we call them and check in with them after they have their experiential session. Just really being supported for them to be supported as they begin changes in their lives, as they begin to feel that there's healing that's happening. When we think healing is happening, it's not all good, because also if you think they have lived in the world in a certain way that now is different. And even though for them it's what they wanted and it's better, it's also going to be challenging. It's also challenging for the families. Many times people with PTSD have different members of the families have played a role in how to keep them safe, how to support them, and those roles begin to change. And so how does the participant begin to talk to their loved ones about how those roles are changing and what it means for them to no longer need the kind of help that they needed before. An example of this is we had a participant whose partner really took care of everything for her, everything, getting the mail, going to the grocery store, doing all the things that required being outside the home. And as she begins to heal, she wants to do these things. And so how does his role change, right? How does he remain up to date with her about what needs to happen to support her in her own changes too? So it's a tricky time, and it's a time that affects their whole system and their whole family system as well. So we really want to be able to support that. I wanted to show a picture of our setting in our clinic. This is the room that I'm in right now. There's two different ways that we can do that we've done in our studies. One of them is this way, where the two therapists are on one side. We have another modality where a therapist is on one side of the bed and the other therapist is on the other side, and the participant is in the middle. I think it's just a preference. Our dogs, you can see our dogs here. Participants often, we ask them and they often want the dogs. The dogs are really therapeutic and they come and lay with them, and very intuitive, know exactly when to come up and when to lay down. Beyond those doors, there's a little river. And so they are able to listen to the river and use the headphones and the eye shades and be very present with them. And we come closer at times and at times go further away. During the preparatory sessions, we talk to them a lot about touch, about how what's going to be comfortable for them. Can they ask for us to hold their hand? Can we ask them if they want us to hold their hand or their foot? So taking a lot of care in supporting their boundaries. We bring flowers. We offer a candle. Sometimes people might not want it, but oftentimes people do. So a little bit of a ritual of how we start the session and how we bring the intention into the room. Sometimes we offer them an animal card. We have cards and they pick an animal that can support them in their journey for the day. So a lot of intention to this first beginning part. So in we just finished the first part of our phase 3 study. So the first study, and we're now doing what we call MAP 2, which is the second study for phase 3, which is our final one before we request from the FDA for MDMA assisted therapy to become a treatment for PTSD. So we're hoping that will happen in 2023. And we are not quite halfway to doing this study, this second part, which is with 100 participants. So we're in that phase right now. We did a phase 2 and where we had very promising results. And now phase 3 is still safety and efficacy, but how do we duplicate? Can we duplicate those results? So phase 2 was only a few studies, and now phase 3 has 15 sites, one of them in Israel, 2 in Canada, and the rest in the US, across the US in different locations. I'm in Boulder, Colorado, and we have 1 location here and another one in Fort Collins. So we have 2 in Colorado. And it's a double-blind placebo. So there's 50-50 chance that they will have placebo instead of MDMA. And we work with it the same way. We treat it exactly the same way. And then when we unblind the study, so we unblind the first phase 3 study when it was finished, and we found out for sure who are the people who got therapy only. And then those people get to enroll in a crossover study, which we're doing right now. And they can get the full treatment again with MDMA. But this takes a while. Like right now we're doing the ones from the first phase 3 trial, and that's about 2 years later they've had to wait. I'm going to show really quickly a couple of results from that first phase 3 study, which we had incredible results. Better than we could have imagined. So you see on the left, we use the CAPS, which is clinician administered PTSD scale. It's like a gold standard for PTSD. The placebo is the blue and the MDMA is the red. So it's a big difference. Still, people improve with placebo, but here's the MDMA. And this is the functional impairment. We do a questionnaire about their functional impairment, how it affects, how their symptoms impairs their life. And this is the results from those as well, from the MDMA. Big change here. And also depression going down. So this is a slide that shows it a little bit better. 67% of our participants by the end of the study no longer met criteria for PTSD, and 21 of them had significant improvement and 12 of them did not. And then the blue shows with the placebo how it's about 30%, and 32% no longer met criteria for PTSD. So that is about what we do with other modalities, existing modalities. It's a bit between 25 and 30%. So that's pretty consistent with that. But if you really think about the one on the left, 88% of people had significant changes and 67% no longer met criteria for PTSD. So, you know, what does this mean? This means that this modality is promising, that it's not going to be for everyone. You know, we still have this 12%, but it's very promising and it does help a lot of people. And we're talking about a medication that you take 3 times. Maybe once post-approval, it will be a little bit different. Maybe somebody needs it 4 times, 5 times, 2 times. But in the study, we're doing 3 times, as opposed to something that you take every single day. This is a little bit of the most common adverse reactions. So we haven't had anybody that has had them for a long period of time. They just last. Usually they're gone by the end of the day, if not the next day. Nobody in our studies has had to get intervention, like going to the hospital or anything like that. And I'll stop there.
Thank you very much indeed, Marcela, for your talk and sharing all this information and experiences with us. So yeah, I'll open up the floor for discussion and questions. One question here from Antti Hupli, if he would like to say it himself. Perhaps Henry, who's hosting, can give Antti a chance to use his microphone. Go ahead.
Hey, okay, great. Do you guys hear me?
Yes, we hear you fine.
Okay, so you already kind of went to this topic briefly, but as you said, the PTSD doesn't just, or the trauma doesn't just affect the individual itself, but also the family members and the close friends. So have you guys seen in the study, do they start to feel better after the PTSD person is being healed, or do they get worse first? Because like you said, they are now able finally maybe to ask themselves, wait, how do I feel? What is my meaning now? And what do I do now? So have you seen and have you tried to integrate also the family members and the close ones in this whole
Yes.
process?
That's a really good question. We definitely encourage maybe a partner or a loved one to be in therapy themselves while this is going on, to really understand this process. But we also ask them, if the participant wants them to be involved, they can come to integrative sessions, even preparatory sessions. We've had people come to those and to really understand what's going to happen to their loved one. What does it look like? What to expect? What are some of the things that we've seen? And sometimes the participant does invite them to their treatment session. We usually ask that they do the first one by themselves, and then if they want to have a family member, their family member can come in a subsequent one, like the second one or the third one, and more towards the end, so they can be a part of it and they can begin to integrate, and that we can also help the therapy team can explain things to the family of how PTSD works. Sometimes they don't really understand PTSD that much. So we do psychoeducation with them and explain, and hopefully they can have support after the treatment, go to therapy, and really begin together that integration process.
Okay, thank you for the answer, and thank you for the presentation, Marcela.
Thank you.
Great. There's a couple of other questions here that the people have asked me to read out, so I can do that here. The first question is, what do you feel is the biggest unmet question in MDMA-assisted psychotherapy? So perhaps what is the biggest unknown still in this field or this sort of therapy?
Mm-hmm. I think one of the biggest unknowns is, who doesn't it work for? And what are the reasons that it doesn't work for a certain population? What is it? We don't know a lot about that. We continue to find out about safety, and that's something that we'll continue to do studies with, because that's an ongoing. There's still some things that we don't know about MDMA, right? That we've had these studies, we've had good results, haven't had any serious adverse reactions, but we're still don't know everything about PTSDs, about MDMA. So that's another one that we will continue to do. But I'm very interested in who it doesn't work for, and how do we need to change the modality based on maybe other conditions. Like, do we need to change the modality if we're treating depression and not PTSD? Do we need to change it for something else if we're treating other conditions? So those are still unknown, and there's still a lot of research that we need to do.
Maybe if the research doesn't yet answer that question, do you have any hunch or clinical observation about perhaps the patients or participants who you felt maybe did not benefit? Is there anything you can speculate on that topic?
Mm-hmm. Speculate. I wonder too where you are in your process of healing, that you come into the study, some people come into the study having had a lot of therapy, and that maybe it didn't take the PTSD away, but it helped, and they learned a lot about themselves. And so they come in and they're in a place where they're not at the beginning of their healing journey. And for somebody at the beginning of their healing journey, maybe 3 sessions is just not enough, right? That they're just beginning to discover some things by the time the study's over. So I think that that's also part of the difficulty with having a study, that we can't offer people who feel that they are just beginning their process and they need more. We can't offer more treatment, right? And hopefully post-approval, that'll be different. That'll be different because then we'll be treating people where they are in their process.
Right. If you had to decide based on experiences so far, would you think this sort of therapy would be suitable for the last parts of a healing process or the start of it? Or where would you place MDMA-assisted psychotherapy if it was a longer therapy or therapeutic process?
Well, I think it would then it would depend on where the individual was, how many that you would do a protocol that fits them, right? That maybe somebody who needs 5 sessions, that hopefully we can provide that, and that they can feel, okay, I have enough sessions to do what I need to do. We haven't found, one of the things that we thought would be different was cause of trauma, that if it was really complex, maybe it would look very different. Maybe if it was war trauma, it would look very different, but we haven't actually seen that. We haven't seen that, so.
All right, thank you. Some other questions that were posted here for me to read. This person would like to hear more about the differences of process regarding PTSD from a single traumatic event versus PTSD from things that have been going on for a longer time, especially in close relationships. Perhaps you just touched upon this a little bit, that there's not that big a difference maybe in the effectiveness, but what about the process perhaps, or what happens during the sessions? Is there a difference in your opinion?
That's what we haven't seen. It was a little bit of a surprise that that we haven't needed to do something different, or I think that people who apply for the study have pretty severe PTSD already, right? So whether it was a single event, most of them, like I had said before, are complex PTSD. Most of them are treatment-resistant PTSD. So our phase 2 studies were about treatment-resistant. They had to have had at least 6 months of therapy or medicines that they had used. So now, we're working with a population that has pretty severe PTSD. And so it's more dependent, rather than it being about the cause of the trauma or whether it was one incident or many, is more about how it has affected their life, how it has compromised the way that they live their life. So I think it's more due to that, and the treatment itself is the same for both.
Right. Another question is about mystical experiences, and what is your stance to people perhaps having mystical experiences happening during an MDMA session? First of all, are they common with MDMA? And would you consider it possibly dangerous if, for example, someone gets a mystical feeling that they have divine inspiration or that they are led by the Holy Spirit instead of being an agent by themselves?
Mm-hmm. So it depends how you define mystical experiences. I find that an MDMA session is a mystical experience myself. So I see it that way. I see that that the mystical experience happens when one connects to oneself. That is a mystical experience. But if you think about mystical experiences in terms of divine, we have had people who have felt they we had a participant who said she was sitting on God's lap, and that was her experience. And so if you consider that it's still, I think one of the ways that why MDMA is so good for PTSD is because there is this sense of myself in it the whole time. That I am maybe getting messages that maybe God is talking to me, maybe my ancestors are talking to me, my grandmother's talking to me, but it's still talking to me, and I'm making that decision of what to do with what I'm hearing and what I'm listening. So it does not feel, I don't think it feels that now it's taken away from me and I'm no longer the agent of my change. I think it really helps the individual connect to that part of themselves, their inner healing intelligence. Their inner healing intelligence, they could call it God. You know, they could call it God, depending on what their beliefs are. But it is about getting the information from within about what needs to happen for the healing journey. And that mystical experiences with regards to religion or spirituality, the divine, are not necessary for healing either, for the healing to occur.
Right. Another question about different types of trauma, or perhaps trauma-related disorders, is whether you've been treating people with developmental attachment trauma who have not any abuse or violence necessarily, but perhaps attachment issues otherwise. Do you have any experience about this?
Yes. So many of our participants whose trauma was as a young child have attachment issues as well, right? So there's a lot of comorbidity with PTSD, one of them being attachment. So it's working with the attachment too, right? Working with whatever presents itself in the session. So when the trauma was as a child, definitely attachment is part of it. And then working with that piece, you know, working with attachment. I think there have also been, we've done a study with anxiety due to autism and the autism spectrum. So there was a study done with the anxiety, also with anxiety due to a life-threatening illness. So we have, and we're working on one that hasn't started, working with eating disorders. So there's many studies that will begin to happen as well, and we'll get more and more information about what is different about treating a different condition.
Do you have any initial thoughts you could share about that? How would the modality of treatment be different, for example, in eating disorders? Is it very similar, the approach you might take, or is there something
we're taking a very similar approach? So maybe the measures done are different, but the treatment itself is the same. And you know, I hope we can continue the integrity of that modality, because we're talking about a modality that is about trusting the participant, that they're the ones that have the capacity to heal themselves, that we're not an expert bringing something in, that we believe in their inner healing intelligence, and that they can create their own change, that they're the agent of change. So I hope that we can continue that.
Before I continue with other questions, maybe this is a good point also to ask about, recently there's been some developments in different types of treatments using MDMA, using perhaps some more CBT-oriented approaches, or this couples therapy or something like that. Mm-hmm. What do you think about this? It would be a good development that there would be a, let's say, a sort of selection of different types of MDMA-assisted psychotherapies. Or are you very convinced that your current approach is certainly the best?
Well, I think it can be incorporated into others, like that it's not, we did do one with CBCT. So it was with couples. We did a study with couples doing when one of the one of them has PTSD and the other one doesn't. So there was a study done with that and using a different, bringing in that other modality. So combining it, right? Like still using what we're doing and combining other modalities. Also exposure therapy. So, I mean, I think MDMA is already kind of, it brings up exposure naturally. It just shows up because the person is confronted with those memories that they were trying to avoid. So also, how does it work with it using actual exposure therapy? For sure, yeah.
Yeah, thank you. It's a question here by Konsta Piironen, if he would like to use his microphone to say it. Henry can activate it. Go ahead.
Yes, just a moment. I will find. What is you think is the addictive potential with MDMA therapy? Like, is it possible to get like the withdrawal so bad after the therapy, so that they like have substance addiction after the therapy?
Yeah, definitely there is. MDMA can be abused, and it's not very high, the percentage. In our studies, we have not seen that. We have not seen that, that in our phase 2 study, we asked if people at the 1-year follow-up, if people had done it, and it was, I can't remember the percentage, but it was pretty low. And I think one person said they wanted to recreate the experience and they felt like they couldn't recreate the experience. So it wasn't something that they wanted to keep doing. And so there's definitely, it's something to keep in mind. And I think it's serious and we need to really keep it in mind, but we haven't seen it. And I think the abuse is pretty low in terms of if you're going to do it in this particular way. You know, I think in recreationally, there has been definitely abuse of MDMA.
Thank you. There's a question about whether you have anything to share about the 1-year follow-up. How are the participants doing? So perhaps this is referring to the first phase 3 study, or what is the latest ones that you could talk about follow-up results?
Okay, so we don't have those results yet. We're doing those 1-year follow-up right now, so we don't have those results. But what I can say is that in our phase 2 study, a 1-year follow-up was much better than when they ended. So it improved even more in the 1-year follow-up, and it was 67%. That was the improvement. Now we have those results when they finish the study before the 1-year follow-up. So if we are to expect the same thing, which is there's still improvement between when they finish the study and the 1-year follow-up, and now we're starting at the same percentage at the end of study. So it's probably going to be higher, I would imagine.
There's some particular reasons why you think this study went even better than the previous ones, or the results look even better?
Wow. I mean, I think it's so wonderful, right? Because it's about, can it be reproduced? Yes, it can be reproduced across many sites and a lot more participants. And I think part of it too, training, you know, we have a strong training program that we train all the therapists that are doing the studies. They come to our training and to really understand the modality and be able to follow it. And so I'm not sure. I think it's just knowing, having more people too, right? It's a lot more people that we're treating.
Right. There's a question relating to the video clip that you showed us. In this video, the participants seem to need encouragement from the therapists in facing something. And the person asking would be curious about the extent to which people still have strong defenses active during sessions, and do they need therapist support in getting past them versus just the medicine being sufficient for getting to a state where they're all mostly relaxed and then healing can just happen.
Mm-hmm. Sometimes they're relaxed and healing happens. Often they're not. This is not an easy treatment. People really, there's a lot of suffering that happens. There's a lot, it can be very challenging and difficult. And so the therapists do want to support, and it does happen where some of their fears, some of their ways that they have known of how to live their life is in the way, and there's fear in trying to face something new. So in the clip that you saw, for her, it was the fear of being empowered. It was that she had never felt that before, that she had never felt the power, and that she thought if she felt her empowerment, it would crush her. And then realizing that it didn't, but she needed us to support that, to say, yes, we can be here with you. It's okay if it looks, if maybe she gets really angry. Like that was one of the things that she thought, what if I get really angry and you're here and I hurt you? And it's that we can say, we can hold it. We can be with you in this process. We can hold your hand. We can be present with you while you go through this journey. So yes, a lot of support.
Thank you. You mentioned here the possibility of aggression. Have you ever faced patients or participants who do get aggressive on MDMA? I guess that reaction would be fairly uncommon, but some people do have sort of partly paradoxical sort of stimulating reactions in a recreational setting. So does this happen in the therapy?
That people can get angry? Yes, definitely. They can be with their anger, that we just create safety. We can say, let me put lots of pillows around you. You can scream. You can, we're just going to keep you safe and keep ourselves safe. And, sometimes we've had participants who fear, like, what happens if I'm going to hurt you? And then we can come up with a plan of, okay, like maybe I'll move further away. Maybe I'm gonna go a little bit further, and is that better? And my co-therapist can be a little bit closer if they're like, I think we had one participant who felt like I'm very small, I'm very short, small, and so he felt he could hurt me. But my co-therapist is 6'2", and he was like, oh, he can be forward and I can be a little bit back. And so putting a lot of safety measures so that they can express, but they can express a lot of anger. Yes. Nobody has been hurt.
That's good to hear. Yeah, thank you. A couple of questions posed by Henry, who's doing our technical hosting. Would you like to say these questions out loud?
Hello? Can you
Yes.
hear me?
Yep.
Yes.
Just 1 second. Okay, so first question. There's criticism that the difficulty in blinding study participants in an MDMA study makes the comparison to the placebo group somewhat problematic, since both they and the therapist can often pick up whether they got the placebo or active drug. What do you think of such criticism?
It's definitely true. That is one of, not always. We have been fooled before. There is such a thing as a placebo effect. But oftentimes people do feel like they know, and it's more about, so it is it is a criticism that is well-founded. And in the treatment, we treat people with placebo that feel that they got placebo. We call it therapy only. We treat them the exact same way, which is we're still there with them for 8 hours. We still play the music. We still suggest sometimes for them to go inside. They do a lot of work. And part of that is also about being with their feelings. Maybe they have feelings of disappointment, or they have feelings that are really challenging for them when they feel like they don't have MDMA. Being with those feelings, but still treating it the same way. So we are, of course, it's different. They don't have that support, and they are there because they want MDMA. So there's a lot of feelings that come up because of it. And, you know, fortunately, they will be able to do their treatment in the future. And sometimes this is still hard because they have to wait quite a long time. But it is something that is really difficult to be completely blinded.
Okay. And as for the second question, you talked about connecting with an essential self with the help of MDMA therapy. What precisely do you mean by an essential self? Do you think such an essential self as something that somehow already completely exists and is just waiting to be found, or more like something emergent, perhaps like a potential for growth and more complete integration of different aspects of the person that might become actualized through a healing process?
Wow, that is a really well-stated question. I think is connecting to a part of themselves that was before conditioning, before the conditionings that happened. And who is the self that is, I mean, I think, yes, all the things that you said, absolutely. It's also about what we can discover about ourselves, self-growth, who we can be, who we want to be as individuals. So it's the possibility of being able to achieve that, right? That what comes in is the possibility that I can be who I want to be in the world and can affect people the way I want to affect people. That's our essential self. So it's beyond conditioning, is understanding our conditioning, but also bringing in this other part of ourselves that that has possibility, where there's curiosity for the world, where there is curiosity for oneself and for what I'm capable of doing and how I can grow from that place. I'm not sure if I'm answering it exactly, but that's the way that I see that essential self. That is, the critic is kind of takes a little bit of a step back. The judge, these parts of ourselves that get in the way of saying who we really can be in the world. And then, and that it's also that possibility sometimes is there for the first time, that when somebody's been suffering with PTSD for a long time, they don't really believe that there is a possibility of a different present and a different future. And they've lost that connection, right? They've lost that connection to that part of themselves. And it's about, it's a way of reclaiming oneself.
Right. There's a question here by Katri Uusiniitty. Could give her the opportunity to ask her question using her microphone if she wants. Go ahead.
Hi, can you hear me?
Yes.
Yes.
Okay, good. Just a second, I look for my question. I asked about those people who, I know a few people who take psychedelics by themselves, like independently, to every once in a while to improve their mental health and like seeing things more clearly. And I was curious to know what do you think about that kind of self-therapy without any real counseling or therapists involving?
I think psychedelics for self-growth are important, and it can be incredibly healing, and like you said, bring a lot of clarity to oneself. I think the part that I would caution is that piece around trauma, that maybe somebody doesn't even remember some things about trauma, their own trauma, doesn't know that that's what's going to come up, and if they're in an unsafe situation. So I've had in my own practice a lot of referrals from people who have done MDMA on their own, and it has been re-traumatizing, just in the sense that the person they were with could not hold some of what was going on, so they didn't feel the safety, and it just became traumatic because they couldn't feel that. So I think it's using it with a lot of awareness and creating a lot of safety, so that they can have a powerful experience that is helpful instead of traumatizing.
Okay, thank you. That was very important.
Right, I think we have time for a couple of more questions. One question here from an anonymous attendee was that he or she believes that this, what you call the healing intelligence, could be invoked by many different modalities other than MDMA. Do you believe that in the future MDMA will be used, or could it be replaced by some other, perhaps natural plant medicine, or perhaps some non-chemical process breathing practice or something like this?
Yes, I mean, I think MDMA is not going to be that this is it. This is the modality people should use, or this is what should replace everything else. Absolutely not. I think it's the wonderful part of it is that when we can have access to it, then the people who want to do it can do it. The people who feel that they want to use this modality, it's, you know, like I said, it's not going to be for everybody. And there are other ways of achieving healing through non-ordinary states, including non-medicine, like holotropic breathwork, for instance, right? That could be meditation is another one that can create a non-ordinary state where healing can happen. So there's a lot of different modalities, and there's a lot of different medicines, different psychedelics that can help an individual. So absolutely.
Thank you. There's a question about integration here, about the integration of the therapy session. What would be the most common practices or ways that you do this integration? What are your best practices there?
Yeah. So we do, it's important for us to do the first integrative session the day after, where the participant is still pretty open and can really have access to what happened in the session. So we help them. Sometimes they don't remember everything. We help them. I think you saw in the clip I was writing. So we take a lot of notes about what's happening in the session so that we can really recall it for them and be able to let them say, to let them expand it. It's like, yes, I felt that. Oh, that relates to this. And to begin to connect dots and begins to say, oh, I realize that I'm in the world in this particular way because of the symptoms that I had with PTSD. So these insights began to make sense. There's a sense of, I understand it better. I understand the way I present in the world, my triggers in the world better. So how do I begin to incorporate and add to my memory this thing that just happened yesterday, right? How do I include that? That becomes part of the experience, right? It becomes part of, I have a memory, that's my memory, this is what happened, this is how I felt about it. Now there's something else that gets added that is a healing piece, like a little seed of healing. How does that affect and impact the way that they function in the world? So I'll give you really quickly an example of a participant who always felt like they were invisible, that they did not, nobody saw them, that they were insignificant. And part of their trauma was this sense of worthlessness, that they did not affect other people, and that so much so that people couldn't see them. And then what happened during the session was that they discovered a part of themselves that was not accepting others, like they didn't let other people in, and that was part of it. And about a week after their session, they went to the grocery store, and the person in the checkout lane told them hello and smiled at them. Have a nice day. I'm happy to, happy you came. And they had never had that experience before. And he realized it was because he looked up. So as simple as that, it was the first time that he looked up and met somebody's eyes. He was no longer invisible. And so it's making these connections so that you can begin to incorporate them into your life.
Thank you. Almost out of time here. Maybe a good question to end with. There was a question here about if this kind of treatment will be possible in Finland. Perhaps you cannot answer that specific question, but since you've presented some of these very promising results and the research looked very promising, what can you say about the future? You said perhaps 2023 in the United States, maybe thereafter in Europe.
And thereafter in Europe. And right now we're doing phase 2 studies in Europe. So right. We hope Finland is going to be right there too. And I think it's, begins to grow in that direction. Yep. And in South America too. I'm from Colombia, so I'm hoping to take it to South America as well.
Yeah. What else can you say about the future? How would you see this being implemented, this form of therapy being implemented in different, will it be very different in different countries, or what do you think?
I think, having clinics that are where people, therapists are trained in doing psychedelic work, psychedelic therapy, especially MDMA, and that people can go to different clinics all around Europe, all around the United States, and in other parts of the world as well. We're getting people from other parts of the world doing our trainings because they want to be able to bring this treatment to their country. And so the modalities will probably shift and look different depending on the culture, right?
Right. Thank you. Thank you very much for answering these questions and your wonderful presentation and being with us tonight. It was really enlightening talk, and really wonderful to hear from an insider's perspective, from a therapist's perspective. Any final words or thoughts you might like to leave with us?
No, thank you. Thank you so much. I'm honored, humbled, and honored that you are here, and happy to share this work that we've been doing for a long time. So thank you. Thank you so much.
Wonderful. Thank you so much. I will say just a couple of words about the future in terms of our association and future webinars. So we do have a few webinars coming up this autumn and next month. Professor Emeritus David E. Nichols from Purdue University will be talking to us in English. In October, we'll have Professor Erkki Isometsä, leading psychiatrist in Finland. And in November, Dr. Peter Gasser from Switzerland, psychiatrist and psychotherapist, will be talking to us. So these are upcoming. If you would like to, if you are not already a member of this association, you would like to support us, you can buy a sponsor membership. It's open to everybody. And if you are a professional or student in an appropriate field and are looking to do research with psychedelics or actively support it, then you can become a full member. At least you can follow us on social media to find out about future events. a warm thank you to all our attendees and especially to our speaker tonight, Marcela Otalora. Thank you.
Thank you so much. Bye-bye.